Hello, my name is Dan Kelly, and this is my first video case presentation. This patient was a 77-year-old male with past medical history of diabetes, PVD, well-controlled hypertension, hyperlipidemia that was on a statin, atrial fibrillation, who came into the hospital today at the request of his cardiologist because he had a cold, mottled right foot. When I started talking with this patient, he told me that these symptoms began over a year ago, and he's had 6 episodes over that course of time. There have been multiple interventions tried. The last episode was on the 18th of this month when he presented with complaints of acute right foot pain and coldness. Subsequently, he was taken to the cath lab by Dr. Cunningham on that date. He underwent stent placement and a femoral tibial graft. His symptoms improved, and he was discharged from the hospital with increased perfusion to that right lower extremity. He reports that when he got home, the right foot became painful again. He describes the pain as sharp and stabbing and aching. Nothing relieved the pain. When he had his foot elevated, the pain was somewhat relieved, and he also had some Norco, which he was taking for it, which did help at that time. So when the patient returned back home, he noted that this occurred again. He spoke to Dr. Cunningham. Dr. Cunningham told him to come in, and they started him on a TPA infusion to see if that would help with the clot. When the patient arrived up to the ICU unit, he had a TPA infusion infusing into that stent. In addition to his past medical history, the patient has had an appendectomy, 3 cardiac catheterizations, one in 2017, one in 2018, and one prior to those that he did not recall the date of. He's had carpal tunnel surgery, he's had a femoral tibial graft, he's had rotator cuff surgery, and that was it. Social history: the patient is a former smoker who quit in 1992 and has since ceased all tobacco products. He denies any alcohol use, no drug use. He is sexually active, and he lives at home with his wife, who he's been married to for 58 years. They own their own home, single story. He's active in his church and has a good support system. Patient's family history includes heart attack for brother who is deceased, and that was 1978. Hyperlipidemia from mother. He is unsure as to what she died from. Father had hypertension, and he died of an MI. Sister also deceased in 1970 from a stroke. Patient has allergies to penicillin only. Review of systems. Patient denies any fever, chills, mental status changes, no blurred vision or photophobia. He is positive for hard of hearing. No tinnitus, nor sore throat, no thrush, no chest pain or edema, no shortness of breath. He does report a chronic cough with clear sputum. Denies abdominal pain, diarrhea, nausea, vomiting. No dysuria or hematuria. No arthralgias or myalgias. Negative for rashes or lesions. No polydipsia or polyphagia, and no negative for headaches. When I was examining this patient, his temperature was 97.6. Blood pressure was 113/64. His MAP was 84. Heart rate was 76. Blood pressure 15. Sats were 97%. Current weight was 138 pounds. On his pain scale, he was 10 out of 10. And he was getting oxygen 2 liters through nasal cannula. Physical exam: patient was cooperative, alert, no distress, appeared stated age, sitting in bed. Normal cephalic, no obvious abnormalities, atraumatic. His eyes were perla with non-icteric. Nares were unremarkable. Septum was midline. Lips, mucosa, tongue were unremarkable. Teeth and gums were unremarkable. They were his own teeth. Neck was subtle. tracheal was midline. Lungs were clear to auscultation bilaterally. Respirations unlabored. Chest symmetry was equal and appropriate. No tenderness or deformity to chest. Heart sounds were heard, S1, S2, no murmurs or rubs noted. Abdomen was soft and tender in all 4 quadrants. Right foot had absent pulse. Popliteal pulse was present, but no pedal pulses or dorsal pedis pulses were felt or heard on Doppler. Right foot was mottled, cyanotic, with pale digits, +2 pulse to the left foot, and he was awake alert, equal strengths throughout all extremities. Like I said, the patient was arrived with TPA infusing. So we're going to continue the TPA. We're going to do neurovascular checks on him. Our cardiologist was on board. We're going to continue the alteplase, keep him NPO, keep him on strict bed rest, check pulses, Q2 hours. We're going to do neuro checks on him Q2 hours due to the fact that he's on alteplase. For his, and that is for his right ischemic foot, secondary to severe PVD. For his diabetes mellitus, we're going to switch him over to a low-dose insulin sliding scale. We're going to continue his low tensin and hydrochlorothiazide for his hypertension. We're going to continue his simvastatin for his hyperlipidemia. We're keeping him on his metoprolol for his atrial fibrillation. We're going to not put him on SCDs due to the occlusion to the right limb, right lower extremity. The patient is currently still on TPA, and then we're continuing. We're going to continue his Protonix for his PV prophylaxis. Thank you.